We welcome you to the 9th session of the East African Journal of Neurological Sciences Journal Club, the Critical Appraisal Bootcamp. So my name is Solomon Kanyago. I'm a final year medical student from the University of Nairobi, and I'll be your moderator for this session, representing XYZZ Research Department. So by way of introduction, the East Africa Journal of Neurological Sciences Journal Club is a collaborative initiative by the East Africa Journal of Neurological Sciences, together with the Kenya Association of Physicians, a Journal of Obstetrics and Gynecology of East and Central Africa, and the Anatomy Journal of Africa, as well as the Annals of African Surgery. So we are proud to host this partnership with XYZZ Med, SCORI Research Exchange, the University of Nairobi Research Club, Kenyatta University Medical Research Club, and the Student Surgical Forum, SSF. Through this bootcamp, our goal is to strengthen scientific critical appraisal skills, deepen engagement with African journals, and build confidence in research interpretation, publication, and peer review among medical students and early career researchers. So what's our today's focus? So today's focus is diagnostic accuracy studies. Today's session centers on the critical appraisal of our diagnostic accuracy study with insights from the Journal of Obstetric and Gynecology of East and Central Africa. Diagnostic accuracy studies are fundamental to clinical medicine. Every day, we rely on tests, that's including laboratory markers, imaging modalities, screening tools to guide decision making. But how do we know if a test truly works? Tonight, we examine key concepts such as sensitivity and specificity, positive and negative predictive values, likelihood ratios, the role of our reference to gold standard, spectrum bias and verification bias, clinical applicability in low resource settings. Understanding how to critically evaluate these elements ensures that we adopt diagnostic tools that are not only statistically sound, but also clinically meaningful in our context. So what's our agenda for the day? So we'll first have a 15 to 20-minute presentation led by Grace Chika from SSF, who will take us through the diagnostic accuracy paper under review, highlighting the index text, our reference standard, study population, methodology, and main accuracy measures reported. Then we'll have a 30-minute open discussion where we'll collectively appraise the study, focusing on methodological rigor, potential biases, interpretation of sensitivity and specificity, external validity, and implications for practice in our region. Then later, we'll have expert insights. We are honored to have Dr. Brenda Kiende, an associate editor at Journal of Obstetric Gynecology of East and Central Africa, who will provide editorial and methodological reflections on the study and on publishing diagnostic accuracy research. And as always, we encourage everyone to actively participate, share your thoughts in the chat, raise your hand, and engage respectfully. This is a collaborative learning space, and your questions and perspectives are highly valued. With that, it is my pleasure to invite our presenter, Grace Chika, to take us through today's paper. Grace, welcome to present.
Okay, thank you. So today we'll be critically appraising a paper that is titled Accuracy of the Urine Dipstick Test for Detecting Asymptomatic Bacteriuria in Pregnancy in Kenya, a rethink of the testing strategy. And those are the lead authors, Smully A, Kamal RK, etc. So just a bit of background around SSB. So SSB is asymptomatic bacteria, and this is the presence of live bacteria in the urinary tract without symptoms. So if the count is greater than 105 colony forming units, that's SB. But if it goes above that, we'll now have a UTI with the common features of fever, dysuria, etc. So in pregnancy, which is a critical part of this paper, SB can lead to adverse outcomes such as preterm deliveries, fetal growth restriction, preeclampsia, that is high blood pressure in pregnancy, and low birth weight if it's left untreated. Routine screening is crucial, but the current methods, which we're going to mention within the paper, face significant hurdles. So the gap that the paper identifies is that the quantitative urine culture, the one that is stated as the gold test for testing SB, has some limitations, such as it's costly to the patient, it's time consuming, and also it requires special equipment and trained personnel. Thereby, it limits the use within low resource settings, such as the one we are in here in Kenya. There is also a variability in specificity and sensitivity of this test in detecting SB. And we know that these aspects are very important in determining the utility of a diagnostic test. And the local relevance is that the Ministry of Health currently recommends that these Dipstick tests are used due to their affordability and ease of use, but as we've seen, they still have their limitations, and it leads to a lack of consensus on the most appropriate diagnostic approach between the urine culture and the dipstick, and we'll be able to compare them with the paper. Yes, next slide. So before we dive deep into the paper in terms of the methodology, the results, and the discussion, just to highlight a few terms that are important, especially in understanding the utility of diagnostic tests. So we have sensitivity. This is the ability of a diagnostic test to correctly identify patients who truly have the disease. So that means that a negative result or a highly sensitive test rules out the disease, and this is mainly used in considered for screening tests. So when you're screening for a disease, yes. Then specificity. This is the ability of a diagnostic test to correctly identify patients who do not have the disease. This means that a positive result on a highly specific test helps rule in the disease. So because it helps rule in the disease, it's usually used for confirmatory tests. Then we have the NPV, which is the negative predictive value. This is the probability that a patient does not have the disease given a negative test result. And it usually depends on the disease prevalence. So it means that if the disease prevalence is low, the NPV is also low. Similar to the positive predictive value, which also depends on the disease prevalence. So if it's high, if the disease prevalence is high, it means that the PPV is also high, which is the probability that a patient actually has the disease given a positive test result. Then we also have the positive likelihood ratio, abbreviated LR with the superscript plus, which just alludes to how much more likely a positive test result in someone with the disease than without the disease. So in LR, there are ratios to it. So if it's 1, it has no diagnostic value. And as the number increases, so we have greater than 10, it shows that there's strong evidence to rule in the disease. Then we have the term gold standard, as we mentioned, for the quantitative urine culture. So this means that this is the best available method for diagnosing a disease against which other tests are compared. So gold standard is not a set one, because even as the medical industry evolves, there's a lot of advancements in terms of diagnostic tests, so this can change. But for our case, we have the quantitative urine culture. Then we have accuracy and precision, terms that sometimes may be confusing, but accuracy refers to how close a test result is to the true value. Then precision refers to how consistent a test is, especially when you carry out repetitive tests. So if you have serial testing, how consistent are the results that you get is what is referred to as precision. Next slide. So we'll continue with the content of the paper. So for the study methodology, we look at the design, the population, the procedures, the setting, the timeline, which is the duration, the data analysis, the criteria, and the ethics, which is important. So the study design, this was a cross-sectional study that use the population of 132 women of legal consulting age. Then the sample procedure was that eligible candidates were briefed, so they were taken through what the study entails, and they were given questionnaires so that we could get some information on the demographics and the reproductive health information. And the study took place in Kenyatta National Hospital, which was the preferred setting, especially at the antenatal clinics, because remember, our population was pregnant women. Then the study took place between November 2017 and January 2018, so about 3 months, give or take. Then for the data analysis, the data that was collected was analyzed through SPSS version 21, and a chi-square test was used. For the exclusion criteria, it was not really defined in the paper if it's exclusion or inclusion, but yeah, I hope you get the gist. Yeah. So if the pregnant mother had prior symptoms of UTI that are suggestive of UTI, that is fever, dysuria, frequency of micturition, they were excluded, as we talked about SB being that there is presence of bacteria, but only when it's less than 105 colony forming units. Then if there is presence of vaginal bleeding or discharge, this was also excluded because it will lead to contamination of the midstream urine that they were targeting as the sample for analysis. Then if there is draining of liquor, that also disqualifies the participant because it will also contaminate the sample. Then if there is prior antibiotic treatment, this means that the colony, the amount of bacteria within the urine might be inaccurate depending on because the drug might still be in the system. Then ethics approval was through Kenyatta National Hospital. So next slide, please. So this is just a flow diagram of how the procedure worked. So we will start with patient screening by identify eligible pregnant women, because we had 132 eligible participants. But remember, this is not the standard number of the pregnant women that were visiting the NC clinics at KNH. Then we'll have sample collection, clear catch, midstream, urine specimens. Then we'll have concurrent testing, so that's simultaneous deep and lab analysis. Yes. Then the markers of SB in urine dipstick. So this was either presence of LE, which is leukocyte esterase, or nitrite, and they were compared with culture. Then the accuracy of the urine dipstick was estimated using culture as the gold standard, as you mentioned. Next slide, please. Yes, so this was just a bar graph chart just showing the participant flow. So we can see that 320 women were screened, but some of them were excluded. That 59% were excluded due to the criteria that we used. Then we remained with 132, which is 41%. Then out of this 132, 2 urine samples were lost. Then now we remained with 130 eligible samples for analysis. Among these 130 samples, the prevalence of SB was found to be 6.9% among the analyzed samples. Yes, then for the mean age of participants, it was 30 years, with over half the participants aged between 26 and 35 years. Then we looked at the data, the paper looked at the data using different socio-demographic information such as marriage, employment, and education, but they had no significant association to the results of the cultures. Next, please. Then these are just the key findings. So remember that you're trying to compare which is the best diagnostic test for ASB, especially in pregnancy. So we have Dipstick and we also have culture. So this is just a bar graph to show the differences in the detection rates of ASB between the two tests. So you could see that culture, when urine culture identified ASB in 6.9 samples, the Dipstick showed a higher positivity rate, especially for the leukocyte esterase and the nitrate. Then we also have leukocyte esterase only, the nitrate only, and now both of them. This would indicate a high number of false positives with the Dipstick method, particularly for leukocyte esterase. Next, please. So now we look at the diagnostic accuracy of urine dipstick. So we have sensitivity and specificity terms that we've talked about. So for the leukocyte esterase, we'll see that sensitivity was lower than the specificity. For nitrate, we'll also see the same trend of sensitivity lower than specificity. And as you can see the numbers, you'll see that the nitrate test showed high specificity, that's 97.5%, but it had low sensitivity. Then for the leukocyte esterase, it had high sensitivity, but low specificity. Then a negative dipstick test. So when you have when you assess both the leukocyte esterase and then nitrate negative, it ruled out ASB, demonstrating that a high negative predictive value, that's the NPV of 98.9% for either leukocyte esterase or the nitrate. Next page, please. So according to the results that the data that was collected and analyzed, there were important implications for practice and policy. And something to note about the paper is that it was the first study in a Kenyan setting to test the MOH policy of urine dipstick against the usual gold standard, which is the culture. Therefore, it has critical data that is useful for both policy and practice. Remember that was a local relevance, and yeah, it adds on to the data, full of data within SB testing in pregnancy. And the paper also noted that a negative urine dipstick test effectively rules out SB in pregnancy, and it eliminates the need for routine culture. However, a positive dipstick test, especially for leukocyte esterase, has low accuracy and requires confirmatory culture testing. Then treating both based solely on a positive dipstick could lead to unnecessary antibiotic exposure for 23.6% of pregnant women. So if you expose them unnecessarily to antibiotics, there are side effects, and these include increased drug resistance and higher cost. And remember that AMR is a pandemic, and we shouldn't be contributing to that. Yeah, so that's why it's unnecessary to expose them, and it's also dangerous also for the baby. The high false positive rate for LE suggests that it indicates pyuria, which is the presence of white blood cells, because leukocyte esterase, yeah, it comes from white blood cells rather than definitive bacteria. Then the paper also noted that the high specificity of the nitrite test is valuable for excluding SB, though its sensitivity varies. Then, yes. Next page, please. So the aim of this study was to rethink the testing strategy to find out which diagnostic test between the dipstick and the quantitative urine culture is best suitable for pregnant women. So we talked about the aspect of cost, affordability, time, specialized personnel, and all that was taken into account. So we have the initial dipstick screen. So you perform an initial dipstick test for all pregnant women to exclude those without SB. But beyond that, you'll have to do now a confirmatory culture that confirms the testing. So we'll have only the positive dipstick cases from our initial screen go through the confirmatory culture testing of their urine, rather than empirical testing, which would expose and unnecessarily expose them to antibiotics. Then this will ultimately lead to resource optimization, as it ensures high diagnostic performance, reduces laboratory costs and workload, and also prevents unnecessary use of antibiotics on the pregnant mothers. So in general, this revised strategy will ensure that pregnant women are not subjected to unnecessary antibiotics, which have cost implications, because remember, MR is costly in treatment, and it also increases the risk of drug resistance and side effects for both mother and fetus. Next page, please. So in conclusion, after the study, this seen the implications on both diagnostics, policy, cost implication. At the point of care, it is recommended that the negative urine dipstick test effectively, excluding SB in pregnancy. However, the sensitivity of either test alone or in combination is insufficient for detecting SB due to high false positive rates. Therefore, a positive test requires confirmation, just as we did the initial screen, and now we go to the confirmatory test with culture rather than empirical treatment. And the priority actions that are recommended in the study is that all dipstick positive cases must undergo confirmatory culture testing, which is the Rethink strategy of testing SB in pregnancy. Then ensure appropriate funding and resources to enable culture testing, starting with equipping existing facilities and later low-level facilities with trained and staff and supplies. Because remember, this was a factor that was limiting the use of culture as quantitative urine cultures for in testing for S, because we had time consuming, and we also had the requirement of specialized personnel and equipment. Yes, that is the paper. Thank you.
Thank you so much, Chris, for such a and a great breakdown. And with that, I'll welcome Felix to guide us to the 30-minute open discussion.
Good evening, everyone, and thank you so much, Grace, for that wonderful summary of the paper. So at this point, we will have our open discussion. Let me just make sure that the chat box works properly. Okay, yeah, great. So we'll go straight to the title and to the authorship. So anyone we would like to open the forum for us today? Did the title meet the requirements? Was it a good summary of what the paper is about? Did it include the test, the target condition, the design, and maybe also the setting? So, and also was the authorship also sufficient? Anyone who'd like to unmute, you can raise your hand, and then Solomon will unmute you, and then we can proceed. And then you can remember, once you unmute, introduce yourself, your affiliation, and then go ahead.
Maybe you can start off from the chat. Christopher
Okay, sure.
Jackson. Good. Only shortcoming is that it doesn't mention the study design. That's cross-sectional design. And Zipporah Wahu says the title is the diagnostic test being investigated. The study population is well held. The study design is not stated. The design is well stated, but the individual responsibilities are not stated. That's from the chat box.
Okay, yeah, I've seen two hands up. Margaret, you can go first, and then Teddy, you can also follow.
Okay, my name is Margaret Sekota. I'm a medical laboratory technologist at Kenyatta University. So I would say that the title is okay. So we have the test, which is the Dipstick. We have the standard or the reference, which is the culture. And then we have the target condition, which is asymptomatic bacteriuria in pregnancy. And then I didn't see the study design of which from the guideline we're supposed to include it. So probably they should have included that cross-sectional study design. And then as for the affiliations, they have been mentioned, and all of them are in obstetrics and gynecology, which I felt was kind of a shortcoming considering the scope of work that they're dealing with. When you look at diagnosis, especially in laboratory, they're supposed to have at least medical laboratory officers, one of the authors. That would be because they are doing like that, the backbone of the results, basically. And then as for keywords, none of the words that are in the guidelines are in these, but at least they've mentioned the asymptomatic bacteriuria, urine culture, and so on and so forth. Yes, thank you.
Thank you so much, Margaret, and that's a very good point. I think it's something we saw even in the last paper we discussed on lupus. There was a lot of lab work that was in the results, but we didn't see much of the affiliation, of the people doing the hard work in the lab included. So that's a very good point of like transparent authorship and including significant contribution. So Teddy, you can next.
For me, I thought that the title is okay, though, because it was not a multi-center study. Instead of saying in Kenya, they should have said that it was done in Kenyatta National Hospital. Otherwise, with the risk of repeating what has been said, everything else is okay.
Thank you, Teddy. Then Lomi, you can go next. And remember to also introduce yourself before you share your thoughts.
So, hello everyone. My name is Lomi Acheng from Kenyatta University, Bachelor of Science in Population Health. So, I think most of the things have been mentioned. I can only add maybe give an example of how the title would look like, because all have been mentioned. So it would read like accuracy of the urine dipstick versus culture test for detecting asymptomatic bacteriuria in pregnancy in Kenyatta National Hospital, a prospective cross-sectional diagnostic accuracy study. I also felt like for the authorship, like it appropriately includes clinicians relevant to obstetric care, but it does not clearly indicate involvement of the laboratory scientist or statistician. Yes.
Yes, thank you. Thank you so much, Lomi, for your contribution. And yeah, so I think that's sufficient. Maybe the only thing I'd add, I think this part is also nice. I think it adds to making the title a bit interesting. So even as much as maybe it adds the study type, which can also be inferred from the accuracy of this test versus this part. But I think also this, because we also, as we are praising, we also talk about the positive. I think it's catchy enough to want you to read the full paper as you wonder what is this rethinking that they are doing. So all in all, thank you for your contribution. So we'll move on to the abstract. So
a question on the chat now.
Oh yeah, go ahead,
Philip.
Yes.
Yeah, are we allowed to put a question in the title? That's wrong. Is that allowed?
Yes. So titles have evolved. I think for the guide we usually share, it's a bit rigid, just like on the main things that should be there. But like a trend, over the past couple of years has been to make titles a bit more interesting and to a bit more catchy. So you see even papers nowadays, it's not always so rigid. as long as it communicates exactly what the paper is, and as a bonus, like catches the eye of people, of the readers, it's a plus actually. It doesn't take away from the paper. It helps it actually appeal more. So thank you for that. So we'll move on to the abstract. So your thoughts on the abstract? Was it a good summary of the entire paper? And did this just, yeah, basically that's it. Was it a good snapshot of what the main event of the full length paper is about? And did it represent everything accurately? Were there anything that you found maybe it misrepresented, or what should have been included that wasn't included? Yeah, all that. So the floor is open. You're free to lift your hand up if you'd like to speak.
Okay, from the chat, Christopher Jake says it's a good abstract, concise explanation of the paper. Falls short in not mentioning the area under ROC curve values for the.
But I think Solomon, you're breaking a bit. I didn't hear that last part. Or maybe it's my end.
Sorry, I can go again.
Yes.
So it's a good abstract that is concise. Explanation of the paper. It, however, falls short in not mentioning the area under curve values for this. Then Aditi says the abstract gave a quick snapshot and easy. The area under the ROC wasn't mentioned. So I think they're similar views.
Okay. Yes. Thank you. Thank you for that. Yes. Anyone else would like to add? Maybe we can have one more opinion. Maybe someone who can unmute, and then we'll proceed to the next part. But if not, I think that's sufficient. I think it's a good abstract, a very good summary. Has the main sections also, and it's easy to just skim through and see the main things. So we can move on to the introduction slash the background. Did it bring out the gap, the rationale of the paper? Did it clearly bring out the objectives? So did it bring out the why? Okay, the what, the why, and the how of this study. So Christopher, you can go.
Hello, can you hear me?
Yes, you're audible.
Okay, so for the introduction, it is a good introduction.
Sorry for interrupting. You can introduce yourself. Please remember to introduce yourself.
Oh, okay, sorry for that. So my name is Christopher Jakes. I am an incoming fifth-year medical student at the University of Nairobi. So my comments on the introduction are that it's a good introduction. It's comprehensive, the rationale is clear, and linked to the resource context. The objectives have been clearly stated, but the biggest issue that I have with it is that definition of asymptomatic bacteriuria is quite misleading, and I think it's due to a typo, but it can seriously affect the credibility of the paper in that the accurate definition should be 10 raised to the power of 5 colony forming units instead of 105 colony forming units. Seems small, but it can seriously influence the credibility of the paper. So yes.
Thank you so much, Christopher. I think it's also something I noted. It's a big error, as it might be. Most likely it was on the editorial side. It's just a superscript because it's actually 100,000 colony forming units. But for anyone who's not familiar with the topic at all, you'd completely get the wrong definition of what asymptomatic bacteriuria is because of this small typo. So thank you so much for that contribution, Christopher. Any additions? Can have maybe two more on the background. Anything else you noticed, or just anything good that you'd like to comment as well? Anything in the chat box, Solomon?
Oh, yeah, there's something in the chat box. So Aditi says the rationale and the purpose of conducting this. They haven't mentioned why culture plates are the gold standard, however.
Okay, yeah, thank you. Thank you for that. Any other addition? Okay, I think that's sufficient. I think there wasn't anything maybe more, but the rationale for the study was good. Was well brought out, in my opinion, as well. And they explained what their gap was is very clearly and exactly what they meant to do with this study. So we move on to the methodology. So for the methods, this is of course I would also hope to have a more detailed discussion as well. So you can comment on all the main parts of the methodology, from the design to the setting, the study population, sample size, the procedures, basically everything they did, and from to ethics and all that, because it's what they did in the study, and that's the main part of the study actually. And is it sufficient to meet the targets? I mean, to meet the goals, objectives that they had, and is the interpretation that they've given from what they've done consistent with what they actually did in the methodology? So Clarence has his hand up. So wait. Clarence, you can go ahead.
Yeah, thank you. My name is Clarence. I'm a fifth-year medical student at the University of Nairobi. I'll try to go through the whole methodology. So for the study design, the authors, they were able to identify the study as being cross-sectional study. They're able to clearly state the setting of the study a little bit later. In the guide, it was talking about blinding. The authors, they were only able to identify that blinding was done to the interpreters of the reference test, so the guys in the microbiome lab doing the culture test, but not the index test. I can only assume that the guys doing the index test were blinded because they were doing it first, but that's not stated. For the participants, the authors were able to define the exclusion criteria, and it's only implied, though, that the participants were selected via consecutive sampling, meaning as they were coming in, they were chosen according to these criteria. Participants also, I thought, represented the clinical population for whom the test will be used, because they were selected only if they attended the ANC clinic at QNH, but the total sample size was not stated in the methodology. For the index test, so the Dipstick test, it was clearly described. There was a box, box 1. I was clearly describing it. Now, with the positive and negative criteria being highlighted and the procedures were clearly outlined, the interpreters of this, I've said, were not blinded to the references result, or we assume they were not blinded. Maybe they were, but it wasn't stated. For the reference standard, it was identified, and the researchers, it seems, ensured that it was applied to all participants, but there was no justification as to why it is considered the gold standard, although I think ideally it should have come in the intro, as someone said. For blinding, I think we've already talked about that. They only stated that the interpreters of the reference standard were blinded to the results of the index test guys, and not the other way around. There was also no note of whether clinical information was available during interpretation. Then for flow and timing, the authors did ensure that all patients received both the index and reference tests, because they split the urine sample into two, sent one to the lab, and as they were doing the urine dipstick test. There was, however, no flow diagram in the methodology section. It was in the results. And there was no patient flow reported, although I might be wrong with that. For statistical analysis, the authors did not describe the calculations for the diagnostic parameters, so sensitivity, specificity, I guess because they thought it was an obvious thing, or someone would understand, but would have been good to know, or it would have been good to include in the paper. And they did not report the 95% confidence intervals for all metrics. And they also didn't include the handling of missing data, even though later on we saw that 2 samples were spilled, so they couldn't deal with them. The authors, however, they did include a sample size justification, and they also stated that they used SPSS version 21 for their statistical analysis, which I thought was pretty good. Then finally, for ethical considerations, it was pretty well done. The ethical approval was stated, and they also talked about the informed consent procedures. Yeah, that's what I got for the methodology.
Thank you so much, Clarence, for that very detailed rundown of your reflections on the methodology. See, Teddy has his hand raised as well. Teddy, you can unmute.
So just an addition, for within the index test, they should have included the brands that they used for the dipstick to make reproducibility, and also in the reference standard, they should have also included the media that they used, conditions for incubation, and the counts method they used for the single specimens. Thank you.
Thank you so much. Thank you so much, Clarence and Teddy, for your reflections, which are very good and valuable for the discussion. As we said, the methodology is very important, and I think just to add maybe a few thoughts on what you've shared. Notice that if you were to also include all that information in the paper, it probably exceed the recommended editorial word count. But what we actually like a lot of what is now being recommended is that people also share out supplementary materials that should go in conjunction with their publication, and it's something that we'll probably also try and implement even going forward for our journal, just to set out the infrastructure in that now people can also share full-length protocols, because you realize sometimes it's not possible to share like a full-length protocol of the exact study that you did every single step, and that is very important. If someone wants to replicate your study, whatever is included in this short methodology is just a few paragraphs enough. Along with material, the data that you analyze, the raw data and the calculations and the outputs from SPSS, for example, all these things are things that we're thinking are important to also share, publish, in addition to just the clean paper. So I think that would also help in the transparency and replicability of the papers. So thank you for your thoughts. I think, Margaret, you can go ahead as well. Your hand is raised.
Hello, Brett Pikuta. So I just have a few things to add on that. Some are concerns, some are props. So like there's this bit where they mention for the inclusion criteria, they're not supposed to be having symptoms or history of treatment for UTI in the current pregnancy. But then when you go to the results, there's a bit, even at the table, you'll see in the table, there's a part where they say history of symptoms and UTI treatment, like 1 month prior. So I'm a bit confused. So no history or history 1 month prior. I didn't get a bit. And then when we mention vaginal discharge, I feel like vaginal discharge is normal. So I think they should have specified which type of vaginal discharge they actually wanted for exclusion. And then for the bit of sample size calculation, I'm glad they put the formula. Then they justified using the prevalence. And then they even went above and beyond. They had 320 participants, which were narrowed down to 132, which is more than the required 118. So props to them. And then the bit on ethics, there was the consent, there was the ethical approval. Although I didn't see anything on data protection, which is a bit of a concern. when we look at that. And then for the sample, there's a part where they say concurrently, and then they tell us now they did Dipstick first, and then they stored the sample in at 4 degrees, then they took it to the lab. So I don't know, English kidogo hapo, but either way, props to them for actually storing the sample at 4 degrees so that there's no multiplication with the bacteria, which actually improves which improves the power of their study. And then taking it to the lab within 1 hour, also props to them for that. As for just like someone was mentioned something about mentioning the brands. There's also like the quality. How were they stored? If they were exposed, then we could get either false positives or false negatives and all that. And then they didn't justify the culture as gold standard. I wish they did, because there are several methods that you can do this. You can do microscopy, you can do urinary electrolytes, you can do several things to figure out if someone has ASB or not. So I wish they justified that. I think that's pretty much it from my end. Yes, thank you.
Thank you so much, Margaret, for sharing your thoughts as well. I think that was lively and very insightful. Thank you all. So maybe Solomon, you can tell us the chat box comment.
Okay, yeah. From Christopher, I hope you can hear me.
Yes.
Okay. So the methodology section is good. There's shortcomings, the inclusion and exclusion criteria explicitly mentioned. Blinding is also not mentioned. Then from Zipporah Wahu, study design. The study design has been explicitly stated as a cross-sectional of pregnant women receiving routine ANC in Nairobi between November 20 and January 2018. The study clear outline finding was done by ensuring the microbiology to the results of the Dipstick test. Participants, all pregnant women of who did not have suggestive symptoms of vaginal bleeding, stroke discharge, or drainage of liquor, or who had not taken in preceding month, were eligible. The exclusion criteria were not clearly stated. The sample size was determined using the Badera formula, to detect the diagnostic accuracy of urine dipstick against the gold standard culture with a confidence interval based on the estimated prevalence of ASB in the Kenyan ANC population. 118 participants were by the final enrollment of 32. Did this requirement, ensuring that the study was sufficiently powered for primary. Then Lorna says there are a few calculation errors. So total positives for LE percent nitrate is 44, not 44. So the percentage is 33.8, and the total changes to 84. I can't really understand what she's saying. If she can unmute and really describe what she meant, that would be fine. Lorna, can you?
Actually, Alona, you can tick the because that's part of the results, the tables. You can go ahead and tick the discussion of about the results and any issues you saw with the results. So, Lona, I don't know whether you're unmuted. Let me just unmute you. Lona, go ahead, introduce yourself, and then proceed.
Sorry for the confusing text. There are just a few errors actually when they add the sums, just this text under figure 1 flowchart of study participants. When they add the total number of those patients who tested positive for leukocyte esterase and nitrite, for leukocyte esterase were 37, for nitrite was 7. So the total will be 44 and not 42. And that will just affect a few other aspects, the percentage and the total number of participants who tested negative for both urine and urine, LE and nitrite. And in the table 1, the sum of participants in this highest education level, the sum comes up to 132. I guess they forgot to remove the 2 whose urine spilled, since all the others, they sum up to 130. Oh, and in page 34, here where they mention that there were no false negative cases occurred when both LE and nitrite were negative. Well, the false negative was there, it was 1, and what was not there was the false positive when both leukocytosterase and nitrite were used to test for positive cases. That's just that.
Wow, thank you so much, Lorna, for that, and for that dissection of the figures and the tables. Some of the ones that are easily bypassed. I also didn't see any of that. So thank you so much. Anyone else would also like to build on what Lorna has said, or maybe give also more clarity if there was maybe something that was misinterpreted? You're free to unmute or use the chat box. Yes, but if you have any additional thoughts that come to mind, you can include them. So for the discussion, anyone with additional thoughts on the discussion, was the interpretation of the results appropriate? Did they highlight any limitations of their study, any biases that they identified? Did they give a good interpretation of and recommendations that are like proportional to what the results are, for, as you know, recommendations for practice and all? And you can also include maybe a comment on that they included this nice section, which is not always very common, that they give a policy brief, which give clear priority actions, which was, I think, very commendable. But I welcome you to share your thoughts on that, as well as any other sections of the paper. Actually, we can just have this as the last open forum before we invite our guest editor. So also on the conclusion at the end, recommendations and the policy brief, any thoughts you have on that, as well as the references here and also up here. So the floor is open. Please go ahead. And also, if you had any additional thoughts that have come to mind on the results, please share them. So the floor is open. Results, discussion, conclusion, references, policy brief. Yeah.
Yeah, I can do the.
Great. Thanks, Clarence, for saving the discussion. So proceed.
Yeah. So for the discussion, it was generally well done. They were able to interpret their findings in light of prior studies and clinical relevance. They were also able to comment on the feasibility and cost effectiveness of the study in East African hospitals, because they were saying that they would advise that only women with positive urine dipstick results should be further tested using urine cultures. So that would reduce the burden on these women. The authors were also able to highlight the limitations of the paper and the strengths as well. And for the limitations, interestingly, they kind of justified it, because they said the setting in which the study was carried out is the same as what the general population will have to go through. So these limitations will not really have a negative impact on the findings and on future policies. But in the discussions, they didn't talk about possible sources of bias. For the conclusion, they're able to provide a concise summary of the diagnostic utility of the urine dipstick in diagnosing ASB. And they implied that the test is promising but inconclusive because of the false positives. They also didn't really suggest future research directions. For the references, for the acknowledgement section, I wasn't I guess it was well done. They were able to thank all the people that helped them, especially at the lab. So that was nice that they included that. For the references are relevant and well balanced, and only 3 out of the 16 were older than 10 years old, but most of them were relevant and they all exist. I checked all of them. And then proper citation was used throughout the paper. For the policy brief, I just went through it briefly because I saw it was just a copy paste of the paper, just summarizing it. But I found it to be pretty concise, and the references are also pretty good. So, but I didn't really go through it like carefully. Yeah, that's what I have.
Great, thank you so much, Clarence, for your thoughts. I think that's very helpful. Yeah, I think that can bring our discussion for today to an end. We shall, one of the future sessions in the timetable, I think 2 sessions away, is a policy paper, as we, so that we also discuss and maybe learn how to move from evidence to policy. But I think this is also a good place to just see that. And it's a very good study, I believe, in terms of also promoting evidence-based practice and the guidelines that are backed by, evidence, and also challenging existing guidelines to ensure that the care that patients get is good enough, even as we, struggle with maybe resource limitations. So that brings the discussion to an end, unless there's one more person who would like to add something else.
There's one additional comment on the chat. Okay, so Margaret says there's a well-labeled flow diagram for study participants, which is commendable. However, negative urine dipstick was 88, while 44 were positive. So there's a total of 132, yet 2 samples were spilled. So yeah, this is, I think, something we've talked about, but yeah, it's a good observation.
Yeah, thank you for observing that. And yes, I think we've seen it consistently throughout all the papers we've appraised. There's always an error in the tables. And yeah, because a number of times it's also handled by the statistician and all. It's very easy to mess up in this area. You may have an excellent study, but then the statistics or the analysis or the presentation of the analysis just maybe pokes big holes in the study. We've seen other studies that we've appraised before that had serious issues in that department. So it's something to also be very careful about when as we conduct our own studies. So I think with that, I'll hand the session back to Solomon, who will guide us in the next session and invite our guest editor. Thank you.
Thank you so much, Felix, for that good guidance on the open discussion. And we are honored to have Dr. Brenda Kiende with us, who is an associate editor at the Journal of Obstetric and Gynecology of East and Central Africa, who will provide some editorial and methodological reflections on this study and also give some expert insights. So with that, welcome, Dr. Brenda.
Thank you, Solomon, for that glorious introduction. Good evening, general members. As you've been told, my name is Dr. Brenda, consultant gyna. So I think this was a very good venture for us to break down the paper done. But most of the authors are actually my seniors, so I just want to put a disclaimer that we are not underwriting their work. However, yes, there are many learning points that we can pick from how the publication was forwarded to our journal. Starting with some of the points that I have written down. Well, usually when we are doing a quality accuracy assessment for journals or other submissions that are being given to the paper, we use various tools, and it's necessary so as we can have some form of validity of the paper to ensure that there's no bias in how maybe patients are selected. If there's a tool that was used, was it tested? Was it reproduced? Was that standard reference applied to all patients equally the same way? And though the results, were they well presented? Was a sensitivity given? And the results, are they applicable to the population of the region that has been the study population was picked from? So usually there are standard tools that we use, depending now as editors, to do the needful. But coming now back to this paper of primary author was Mooley on the accuracy of the urine dipstick versus culture test for detecting asymptomatic bacteria. Someone had asked about the questions, and I think that was well answered, that yes, we usually, sometimes you can have a question as a title just to grab the interest of the reader. That is well usually done nowadays, of late actually. Most journals do that. In terms of the abstract, again, as Felix mentioned, most of the time, because of the word count, which varies from paper to paper, it may be difficult to bring in everything that you need to, or rather the study entailed. You just put now the highlights that if you're going to hand in now to an editor, or if you're putting in the journal and they have like a short clip, maybe on the social media pages, someone can briefly have a read through and just get the major take-home messages. But as what most of you have accurately pointed out, I also seemed to have quite a number of questions arising from the paper. Importantly was being a clinician who's practiced in KNH, I wondered the number of the women over the 1 year. I saw they used a questionnaire, but the questionnaire was not used to wean out the patients. It was more of picking demographic data and reproductive characteristics. So I wonder if they or rather ruled out other areas of bias, like confounding factors like diabetes mellitus, which we know could increase the likelihood of a client having UTIs. The other part I was also questioning about concerned about was the results. I don't know if it's me who didn't understand English, but the part where they said leukocyte esterase and or nitrite. So I wondered, isn't that the same as saying leukocyte esterase positive, negative, then nitrite positive, negative? So what is the difference between those three? I didn't get, but I don't know. I would have loved to be explained to that. I wonder how the consent form would have been good to be added as an appendix. The excluding factors, again, I would have loved if they were in a tool test that now was accurately and objectively assessed all the women so that we can know who objectively qualified and who did not. I don't think, as one of you mentioned about vaginal discharge, in my opinion, was not enough. The other thing was the sample collection. They said that they did it in the presence of a trained nurse, research nurse. But I wonder, were they trained how to get the clean catch midstream, or they just, because you need to train the women, tell them how to get their urine. And the gestational age, I saw they did less than 12 to 28, and more than 28. So I wondered why that specific three groups. And as one of you mentioned, also the laboratory, we were not informed on the quality control. And finally, based on the framework that I gave you, the applicability, yes, they recommended that once someone has a positive or rather likelihood of getting urine dipstick that is positive, then they recommend that you do culture. But then again, they said they qualified all positive leukocyte esterase, including the ones that are trace. Almost everyone, if you do a dipstick, leukocytes most likely might be trace, especially if the sample is not 100% sterile. So I wondered what is the rationale, because that would mean then we would be culturing almost all women. But then again, as one of you said, probably now that could have been a future research point, and also in regards to the comorbidities of the pregnant women that already have, fine, UTI could cause preeclampsia, but what of the ladies who already had preeclampsia? Were they included? Some of those questions. So, but in conclusion, I've listened through the discussion. I'm actually very impressed. Being medical students, you guys I've learned a lot from you. But I agree, probably we could have improved a few things before publishing this document, including the editorial error of the superscript of the 10 to the power 5. But I think it was a good paper. It raised a lot of pertinent questions in our management as gynecologists. And we hope to see now more specific, better research from this team. Thank you.
Thank you so much, Dr. Brenda, for such candid comments and also highlighting more issues and also encouraging us on areas of improvement. And with that, I think I can hand over to Felix for a wind-up.
Thank you so much, Solomon, and also Grace for the wonderful initial presentation of what the paper was, and to Dr. Brenda for graciously attending our forum and also sharing your wonderful reflections, which have added a lot of insight and value to our discussion. So thank you all for joining. So this has been session 9. We'll share the materials for session 10. All the materials are available on the EAJNS website. There's a tab written EAJNS Journal Club, and you'll find everything relevant there. So thank you for joining and for the wonderful discussion. Have a good evening. See you in 2 weeks.